I'm Dr. Susanna Vanderpool. I'm a neonatal and pediatric clinical pharmacist. Something a lot of people tell me is that they're intimidated by pediatric dosing, which is fair, it's very complex, but pediatric pharmacokinetics can help provide context and structure for medication dosing so that we can provide safe and effective medication to pediatric patients. The first part of pediatric pharmacokinetics is absorption. This is really what we're talking about when we talk about the route of the medication. The most classic is oral absorption, and this is what's also most variable. So pH is always changing in the first couple years of life. So this affects how well drugs absorb in the stomach and the small intestine. Some drugs will absorb more or less depending on the properties of the drug and depending on if the pH is more basic or acidic. Motility is slowed early in life. This really means that the absorption of medications is slower. Motility is how fast or how slow a drug moves through the GI tract. So oral absorption is a bit more delayed, but overall it can be higher or lower, again, depending on the properties of the drug. Formulations of oral medications are different. Oral solutions will absorb faster than tablets. Not super relevant for dosing, but something just to know. And then feeding tubes can impact absorption as well. So depending on the placement of the feeding tube, does it go into the stomach? Does it bypass the stomach? That will affect how much of a drug is absorbed. It can also adhere to the feeding tubes. So these are all things that we think about with oral routes of medications, and they're immature in patients who are under 2 years. Depending on the indication, we may prefer intravenous medication versus oral medication so that we can bypass that variability in oral absorption. Intramuscular absorption is also affected. So this is decreased. There's decreased skeletal muscle mass, decreased muscle perfusion. And so in young infants, the intramuscular dose will be the same as the intravenous dose. In older children and adults, the intramuscular dose is lower. So that's a good way to remember that IM absorption is decreased in infants. Skin absorption or topical absorption is increased. This is due to thinner skin, as well as increased hydration of the skin. So there's more water for topical medications to absorb. And then the third is increased blood flow to the skin. And so young infants can have systemic effects from topical medications. So they may actually have adverse effects from medications that we don't think about having toxicity from. And this includes reactions to excipients like lanolin and Aquaphor. After a drug gets absorbed, it gets distributed throughout the body. Neonates are 80 to 90% total body water. So they're essentially bags of water. You've probably heard that before. Adults are only 60%. So that means hydrophilic drugs, water-loving drugs, need higher weight-based doses, and especially young infants, to achieve the therapeutic level in the blood that they need. Fat is decreased. So lipophilic drugs or fat-loving drugs need lower weight-based doses so that we avoid toxicity or too high of levels in the blood. And then albumin, which are the proteins in the blood, these are also decreased early in life. And so this leads to increased free drug and increased risk of toxicity from medication. These are immature until about 1 year. So after 1 year of life, distribution is pretty similar to adults. Changes in metabolism are non-linear. So enzyme activity at birth is low. But as the infant ages, enzyme activity increases. Additionally, infants and children have larger livers to their body size. So this combination with the increase in enzymes means that young infants, usually around 1 to 3 years old, have increased metabolism compared to adults. And then this eventually normalizes back to adult levels. But overall, metabolism takes the longest to mature. It's variable until about 10 years of age. Drugs are mainly eliminated in the kidneys. There are 3 processes that determine renal clearance. The first one to develop is filtration, aka GFR. And this matures at 3 to 5 months. This is a passive process. The active processes are tubular secretion, which matures at 15 months, and tubular reabsorption, which matures by 2 years. So elimination is immature until about 2 years of life. There are some caveats with this. So one that comes up a lot is using GFR calculations to estimate renal clearance and neonates who are 3 to 5 months corrected age. Be very careful extrapolating these calculations to non-typical neonates who have maybe poor growth and other comorbidities. A better marker of their renal function and therefore their clearance and their kidney maturity is urine output and serum creatinine trends. Thank you so much for watching. If you liked this video, please subscribe and let me know in the comments what topic you'd like me to cover next.